Welcome to our third policy briefing, I guess you'd call it, for the campaign to end unwanted medical treatment. And I extend this welcome from the campaign and its collaborating organizations, so there are quite a few of those. My name is Larry Atkins. I'm the president of the National Academy of Social Insurance, one of the collaborating organizations. And I'm happy to be here today as the moderator for this discussion, which just means I get to talk to you first, and then I'm going to sit down and listen. But just to start with, the objective of the campaign is pretty simple. It's really to ensure that all patients, have dignity in honoring their wishes, goals, values, and preferences. The campaign is dedicated to ensuring patients and consumers receive the medical care they want, nothing more and nothing less. There we go. So we have a growing group of collaborators on the campaign. We're now up to about 19 national partners supporting the campaign. We have 3 new ones: the Altarum Institute Center for Elder Care and Advanced Illness, the Catholics in Alliance for the Common Good, and the Women's Institute for Secure Retirement. So we're pleased to have these groups join the effort. And also I'd like to take a moment to thank the Consumer Coalition for Quality Health Care, the Elder Justice Coalition, and Compassion and Choices for their financial support for these lunches. So, we started out in December. We heard from Dr. Bud Hammes, the Director of Medical Humanities at Gunderson Health System in La Crosse, Wisconsin. Dr. Hammes has designed and implemented a very innovative and highly successful advanced care planning model known as Respecting Choices that places the person at the center of the decision-making. And then in March, we had our second luncheon with Dr. Bruce Vladeck, that I know a lot of people know or know of, the former administrator of the Healthcare Financing Administration, which is now CMS. And he has been spearheading what is now a 3-year effort funded by the SCAN Foundation known as Dignity-Driven Decision-Making. So he talked to us about that. A brief that was prepared by Dr. Vladeck and Aaron Westfall from the SCAN Foundation that was that appeared in Health Affairs in 2012 kind of characterized dignity-driven decision-making as a process that builds on previous efforts to define and develop patient and family-centered care for those with advanced illness, more a framework than a rigid structure. The dignity-driven decision-making model emphasizes the centrality of a collaborative process in which patients, their families, and clinicians work together continuously to define the goals of care and how best to implement them. So, we've had the opportunity to hear from and gain a great deal of insight from, 2 leaders in this field, and really about models out there that are up and running and working and interesting. So today, we're very pleased to have a different perspective on these issues. And this is a perspective that really comes from the public policy and the political space around these questions. And as you know, these are issues that have in the past resonated fairly substantially in the political world. And so I'm sure we'll have a chance to hear more about that today. So I'm really pleased to welcome Chris Daw, who is a person who's made substantial contributions to the development of federal health policy, both serving in the administration and on the Hill. Until last week, actually we're intruding upon his post-work downtime. But until last week, he was the healthcare advisor to the National Economic Council at the White House. And in that role, he advised the National Economic Council leadership on a wide range of healthcare issues, especially related to delivery system reforms and issues affecting key populations, including those with advanced illness. Before that, he was the director of delivery system reform at HHS in their Office of Health Reform, where he supported the implementation of the elements of the Affordable Care Act that seek to foster the delivery of higher quality, more affordable health care. And before joining the administration, and actually during the passage of the Affordable Care Act, he was serving as a professional staff member on the Senate Finance Committee for its then chairman, now ambassador to China, Max Baucus of Montana. And there he covered all issues related to Medicare Part A, which anyone who's ever worked in Medicare Part A knows are voluminous. So we're delighted to have Chris here today to share his insights on the various options and approaches to developing high-quality and cost-effective models of care for those with advanced illness, as well as discussing some of the key administration initiatives, such as the recent announcement of the next phase of the Hospice Concurrent Care Demonstration Project, and then hopefully share some indiscretions about, really what goes on in the White House. So we're very interested. So with that, I'm pleased to turn it over to Chris.
Thanks, Larry. And thanks to Brian Lindbergh, if he's still here. I think he's going to sneak out in the middle of my remarks, but thanks for inviting me. It is, there you're on the spot. You can tell him where you're going. It's great to be here. As Larry mentioned, this is my first week outside of public service for a number of years. And I couldn't think of an issue more important to me and to the cause to come and speak to you guys about, and I really appreciate the work you're doing. That being said, the bar wasn't that high to get me out of the house. It's only been a week, but yeah, a lot of diapers. I have a 7-month-old, spending a lot of time with her. I think she's happy to have Dad around, but a lot of diapers, a lot of Hoda and Kathy Lee, a lot of time trying to break in at the playground. It's a tough spot for newcomers, and I don't mean the babies, the adults. You got the nanny, the professionals who are sort of looking at me like I must be some kind of unemployable loser. What is he doing here during the day? And then you've got the moms and the other dads who, are protecting their ground. So it's good to be here with you all talking about issues of national public policy importance. But in any case. And I'm happy to take questions on any of that stuff. But what I thought I could do is talk a little bit about the perspective from the administration as I have to be careful with my we's and they's, as they are looking to implement healthcare reform, both using the sort of new authorities and resources and vision in that legislation, but also sort of existing authority to really help be a partner in the evolution of the healthcare system towards providing care that's of high value to purchasers and, of course, to consumers. So I want to give a little bit of the context in how the administration and its allies have been sort of proceeding with their work, and then talk a little bit about the new Medicare Choices model, or otherwise sort of known as a concurrent care model that was recently announced, that is a really exciting and important addition to the portfolio of models that are being tested, mostly through Medicare, but in some places with dual eligibles, with Medicaid, and with private payers. So I want to sort of set the context, talk a little bit about that, and then I think it would be really interesting, fascinating to me to have a discussion about what might be next and thinking about advanced illness management, if you will, more broadly than just concurrent care and folks who are hospice eligible, thinking a little bit upstream. And what does that mean for the sort of big picture trend and the toward accountable care, if you will, and how a potential model around that may or may not fit into the landscape as, again, I think both public, private payers and others are trying to find ways to be supportive partners of healthcare deliverers who are thinking about how they can kind of change the way that they do business and practice care in the sort of new American healthcare system that hopefully is developing. So that's sort of the general approach, and I won't try not to blab on for too long because it's a great small room. We can have a pretty good discussion. So just sort of stepping back textually, as I mentioned, the general idea that we need to move a system from one that is really focused on, again, you guys have now heard this has become cliche, right, that move from volume to value. And that is now, I think, a consensus position, which is nice for those of us who have been doing this for a long time and feel like, you know, the idea of quality and value was always sort of off to the side, and now it's becoming ingrained in everything we do. And I think that idea that getting more value out of our healthcare dollar is the solution to improving quality, making healthcare more affordable for patients, families, governments, employers, you name it, is one that's shared from, you know, the U.S. Chamber of Commerce to the Center for American Progress. I mean, there's really not a whole lot of debate there. I think the real question is, how do you get there from here? And as all of you know, the healthcare system, there is no single huge healthcare system. It's a very local and regional market, and there's no one way to flip that switch overnight. And so the approach that the administration's been taking, again, given some resources, authority from the Affordable Care Act, is, you know, how can we be a partner in helping folks at the local level kind of unlock innovation that they know can work where they are. And so they have really approached this from really three big buckets of policy work, I would argue. So payment reform, which is sort of, I think most people would argue, is the one of the main and you know, first to recognized barriers to really unlocking healthcare that is really value-driven. So how do we change the way the money flows so that it's actually rewarding for folks financially to keep people at home in the community, out of the hospital, et cetera. The second is around data liquidity, if you will. How do we unleash the treasure trove of healthcare data that certainly Medicare and the federal government's been sitting on for years, but also a lot of private payers. So how do we get that information out into the hands of certainly to providers who are now thinking about, okay, how do I think about managing a population of patients or managing an episode of care that might be beyond the four walls of where I practice? So how do I, you know, get my hands on the information I need to be able to make sure that I'm providing patient-centered, high-value care, but I can track that and know and make adjustments and know how I'm doing. So data for providers, absolutely, and for consumers to put more information in their hands so they can be more empowered in the way that they shop for care, shop for insurance, you name it. So payment reform, data liquidity, or transparency, availability, whatever you want to call it. And then the third being practice support and sort of infrastructure development. This is one that I think was a really important legacy of Don Berwick, who I'm sure many of you know, who is a terrific public servant and a great guy who I had the privilege of serving with for all too short of a time, and I think you guys all know that story. But one of the things that he really ingrained in us as we were pushing this agenda forward was you can't just change the payment system, throw some data at the marketplace and say, good luck, we'll see how you do. If you really want folks to have an opportunity to succeed, you have to help them, meet them where they are, and help them develop the capacity, the tools, and the infrastructure to actually succeed in this new environment. And so there's been quite a bit of work in things like hospital safety and the creation of hospital engagement networks. These are 26 groups that were contracted from CMS to go and work with 4,000 plus hospitals and essentially divvy up the hospital market. And their responsibility is to transfer best practices from higher performing hospitals on patient safety to lower performing hospitals. And in the first year or 18 months, we asked them, okay, focus on six critical areas,